Let me go ahead and start recording. And so we're looking at the Canvas page here. So week 7 already is where we're at. Let's click on the week 7 overview. We can see what's here. So we've got talking about specific synovial joints today. So we'll talk about the knee, the ankle, the hip, the elbow, and we'll talk about some injuries associated with those, some details of some of the ligaments and supporting structures around it. And then we'll switch gears and get into the muscles for the first time on Wednesday. So we'll start talking about gross muscle anatomy. And then on Friday will be our first introduction to actually learning some muscles in the body, okay? And we're gonna start off with the gluteal muscles and the thigh muscles, and those, and that'll be by way of a TBL day, okay? So those notes are already posted. They're ready to go there, so you can start working on that at any point this week. And we will have the IRAT and TRAT when you come in, like normal. And then we'll get into some activities from there, okay? And there's also quiz 5 this week. Quiz 5 is, I'll click on it here so you can see what it's over. Quiz 5 is over the one we did last Friday, the synovial joints, and the one we're doing today, specific synovial joints, okay? So after today, you have the information you need to take that quiz, okay? So yeah, and then this week in lab, let me go back one. This week in lab, we're gonna start the muscle anatomy portion of the lab, okay? So you would wanna click on that handout right there, muscle anatomy lab handout. And this week will be a synchronous lab where I kind of give you an intro of what we're doing with the muscles. We're gonna be learning both muscles on cats as well as humans, okay? So we'll do a little introductory there. Be planned for about an hour and a half for the synchronous part of lab this week. And yeah, so that's what that will look like. Let me just show you one thing as far as the modules go. So if you go back over here to the modules, and at the top here, we had skeleton lab resources. Now we have muscle lab resources. As I mentioned before, you need to complete that consent for cadaver videos before you can even go to this page right here. I can't click on the muscle lab resources page because my student view doesn't let me do that. Yeah, let's see. Amy, are you not able to hear me? Is that what you're saying? Maybe for those of you I can see on my screen, are you guys able to hear me all right? Give me a
yeah, we can hear you.
Okay, good. All right, Amy, unfortunately that means it might just be your connection. Sorry about that. Yeah, okay, so make sure that you go ahead and hop on that consent for cadaver videos and complete that, read that carefully, and then that'll allow you to jump into that muscle lab resources page, and that has all kinds of videos explaining the cat muscles, the human muscles, with other resources there, and that'll be your primary place that you go to get all the stuff that you need to learn the muscles, okay? And we're gonna be studying the muscles for the next 2 months in this class, so it's really a huge chunk of the lab, and there'll be lots of quizzes along the way, as well as leading up to the muscle practical towards the end, okay? So, all right, any questions about what we're doing this week?
I have a question.
Yeah.
Do you know when the lab practical from last week will be graded?
Yeah, it's supposed to be by this week, actually. Yeah, I was just working with the grader today, and her goal was to have them all done by Wednesday. So yeah, it should be. I should be able to release those scores by your lab time, by the Thursday labs.
Okay.
Excuse me, Dr. Sawyer.
Yeah.
Oh, I was curious if so I messed up on like the bones. I would say like the palatine bone instead of just palatine, or will we still get credit for that?
Yeah, we wouldn't mark you down for that, but it might not have automatically given you credit. That's why we have the grader go in and take a look for things just exactly like that, and for little
sounds good. Thank you.
Spelling mistakes. So yeah, that's exactly why we do some manual grading on it. Yep. Okay. Anything else? All right. Cool. Well, we're gonna hop into the specific synovial joints here, and then disorders within each of those joints. And so this is kind of a fun one. where we dive into each of these major joint complexes that we already know some about, and many of us have had injuries of these. And so let's go ahead and start here with this clicker question here on your apps. Go ahead and answer that. What joint connects the shoulder complex to the axial skeleton via a bony articulation? So that means bone-to-bone connection. Where is that shoulder joint complex actually connected to the axial skeleton via bone-to-bone? And as always, guys, I love to see your faces. So if you have the ability to turn your camera on, please do so I can see you. All right, anybody else there on that question? Give you about 5 seconds. Got 64 out of 68, it looks like, if you haven't submitted. Okay. All right, gonna go ahead and shut that off. So let's see what you guys said. All right, so we're kind of spread out there. nice spread. Not nice in terms of getting it right, but nice in terms of spreading it across all the answers. So what joint connects the shoulder complex to the axial skeleton via bony articulation? Well, it's kind of a surprising answer, really. And what it is this guy right here, this sternoclavicular joint. Yeah, so definitely, definitely that's the only one. So the glenohumeral joint, that's the one we think of as the shoulder. That's the ball and socket joint. That one is connecting to the scapula, but then the scapula, as it goes on the back, it's just kind of floating on the back with some muscles. So we don't really have a bone-to-bone connection there. The acromioclavicular joint, we'll talk about that one. That's the clavicle and the scapula. So that one still isn't really connecting. Articulation between the scapula and the thorax, that's just kind of floating. There's not really a bony articulation there. So the one point is right here where your clavicle comes in and gets to your sternum. That's the sternoclavicular joint. Okay, so let's dive into each of these. And when we dive into each joint here, what we're going to do is we're going to talk about a few things. So with each joint, you definitely want to make sure you know what bones are involved in that joint. Okay, so what are all the bones in a joint complex? Then past that, it would be what bony articulations are found in that joint complex. Okay, so we're not just talking about a single joint anymore. We're talking about joint complexes that have many articulations. Okay, so the bones of the shoulder. We've got the scapula, humerus, sternum, and clavicle. Okay, so there's 4 bones in the shoulder. All right, 4 bones. The clavicle, just as kind of a little factoid there, most broken bone in the body. You probably mentioned that in lab as well. Okay, so we got these 4 bones in the complex. And then there's really 3 bony articulations. So the glenohumeral joint, this is the true ball and socket joint. Okay, that's kind of what we think of when we think of the shoulder. Okay, the sternoclavicular joint, that's the one I mentioned before where the clavicle meets up with the sternum. Okay, and then we have the AC joint, and we typically call this one the SC joint. And we would typically call this one the AC joint, the acromioclavicular joint. Okay, and I want you guys to feel both of those on yourselves right now. Okay, so go ahead and put your hand on your collarbone. Right, it's right here. Touch your collarbone. Okay, comes out, and I want you to walk your fingers down towards your sternum. Okay, towards the center of your body, and right towards the end of the clavicle. You'll feel it kind of lip up a little bit. The end of the clavicle kind of has like a little bit of a lip on it. And then right past that lip, it'll dive back down in and you should feel a little bit of a joint space there. You'll feel that lip kind of pop up and then it gets kind of soft in there. It's actually usually kind of sensitive. If you push it in your SC joint, it's kind of sensitive. And then keep your finger on that joint space and do this. And you can feel that clavicle kind of going up and down like that a little bit as you do that, right? And some of you might feel a little bit of popping in there, right? You have a little meniscus in there, just like we talked about in the knee, right? There's a little meniscus in there. So that's the SC joint. That's your sternoclavicular joint. Now keep your fingers on your clavicle and walk it out the other way now. Walk it all the way out distally. Getting tangled up in my cords here. Walk it out distally until you get all the way out there to the acromion. And then again, just keep walking it out. you'll feel like a little bit of a lip, but instead of the lip going up, the lip kind of goes anteriorly on this part of your clavicle. And then right past that, you'll feel kind of like a half moon shaped joint surface. It kind of feels like a little bit of a drop off right there. It kind of drops off. You're in your AC joint right there, your acromioclavicular joint. That one moves quite a bit when you abduct your shoulder too. So you're going up and down. You probably feel a little click in there, maybe if you've been an overhead athlete of some sort for a while. Yeah, so that's your AC joint. Okay. Has anybody separated their shoulder? Have you had that diagnosis? You had a shoulder separation? Brett's going to lead the way again with injuries. Thanks, Brett. Yeah. So a few of you said yes for sure. So when you have a shoulder separation, that's actually damage to your AC joint. Okay, and I'll show you that on the slide here in a sec. Okay, questions about those so far? Okay. All right, so let's talk about the SC joint first. So the sternoclavicular joint is the articulation between the sternum and the clavicle. So you can see it right there. Okay, this again is the only bony attachment of the shoulder to the axial skeleton. Okay, also known as the SC joint. Okay, painful one. If you sprain this guy, it's quite painful. It moves around a lot, surprisingly, and because that little meniscus in there, it can be quite painful. Okay, so that's our SC joint. AC joint is the articulation between the acromion process, that's the A part, and the clavicle, that's the C part, also known as the AC joint. Like I just mentioned, when you sprain this joint, that is what's called a separated shoulder. Excuse me. And so we can see that joint right there. So you were kind of walking your finger out on the clavicle, and then right before you get to the acromion, you can feel that joint space right in there. It feels like a little kind of dip.
I have a question.
Yes, please.
So you know how some people can like pop their shoulder out and pop it back in, and it's like a pretty normal-ish thing for them to do?
Yeah.
What would be the actual like situation surrounding that?
Well, let's wait till we get to the glenohumeral joint, because that'll be the next one. That's
Okay,
part of
perfect.
that. But yeah, I'll definitely talk about that for sure.
Awesome, thanks.
Yeah. And so we got all these different ligaments that hold the clavicle to the scapula, or the acromion to the other part to the coracoid process there. And so when we separate our shoulder, the clavicle actually moves upwards right here, right? And so if you've seen somebody with a separated shoulder, then it looks like this, right? You got that big thing sticking up, that's your clavicle sticking up, right? Because usually it is an injury like this, some kind of mechanism where you have downward force on your acromion, right? So something that knocks your acromion straight down and your clavicle goes up away from it, right? That's a shoulder separation. Okay, and we can see what the x-ray looks like this. There's no broken bone in there, but that AC joint is now separated. Okay, so it's different than a dislocation, all right? That's not a shoulder dislocation. That's a shoulder separation. That's a different injury. Okay. All right, the one thing that can be kind of tricky with this is it's really hard to tell when you see that big bump up there. It's hard to tell whether that is just the end of the clavicle or that's the middle of the clavicle and the clavicle's broken, right? Because they both cause a bump like that. So if you have a fractured clavicle, it also sticks up like that, right? But it would stick up kind of further back here, most likely, instead of on the very end. But it's hard to tell without an x-ray, right? So a lot of times you definitely want to get an x-ray with a separated shoulder so you can tell if your clavicle is actually broken or not, or if it's just the shoulder separation. Not just, it still hurts, but it is different treatment. So, okay, so that's that one. And then we get to our main bony articulation in the shoulder, which is the glenohumeral joint. Okay, so it's the articulation of the humerus with the glenoid fossa, the glenoid cavity, okay, of the scapula. All right, this is the joint that has the greatest range of motion. That's what ROM means. Range of motion. Greatest range of motion of any joint in the body. Okay, it's very low on bony support and ligamentous support, just like we talked about last class, right? It's got some ligaments, they're really weak, they don't do a whole lot as far as support goes. And the structure, like I mentioned, is this. It's that golf ball and the tee type structure, right? Where the humeral head is much larger than that glenoid cavity or that glenoid fossa that it goes into. And so we don't have a lot of bony support. And it's just not a very deep cavity, right? It's pretty flat. That socket part is pretty flat. So we don't get a lot of support from the bony structure itself. Okay, so it's only a quarter of the size of the humeral head. Okay, and so when we dislocate our shoulder, we do obviously different than separate. When we dislocate our shoulder, it's typically when this humeral head moves out of the socket of the glenohumeral joint. And yeah, people that that have super loose shoulders, they've done that a bunch. Sometimes they can kind of slip that humeral head posteriorly and then kind of pop it back in. It kind of goes back and forth. And that's typically what that would be. So yeah, so there are some shoulder ligaments that I want you to know the names of, okay? And so with each joint, the ligaments I have here written over here on the slide would be the ones I want you to know, okay? Some of these images have more ligaments on them than what I have written on the slide, so you don't need to know every one on the images, but you need to know the stuff I have there in text, okay? So we have the coracohumeral ligament, okay? And the nice thing about a lot of ligaments is that they're named for the two bones that they touch, right? So we got the coracoid process and the humerus, right? So the coracohumeral ligament goes right from the coracoid process, which is right there, over this way to the humerus, okay? We can see that it's on the superior, anterior superior aspect of the joint. So what does that mean? That means it resists movement anteriorly and superiorly. And that's what it's good for. So it doesn't let your humeral head slide upwards and anteriorly, or it tries to stop it from doing that a little bit. And then we have this kind of ligament complex called the glenohumeral ligament. And it's actually 3 separate ligaments. And they, most of them, the complex really resists anterior movement, okay? So it stops your humerus from popping out anteriorly. And these are really loose, really weak in most people. And then some people don't have them at all. Okay. How many people have dislocated a shoulder before? Leave your hand up for a second as I scroll through. Okay. Yeah, got a couple there. Yeah, got a few. Yeah, so it's somewhat of a common injury, right? It happens quite a bit. When I was working for this arena football team, I was the athletic trainer for a semi-pro arena football team in Fresno called the Fresno Coyotes. I don't know if anybody was watching arena football at any point, but it was kind of the guys that didn't make it to the NFL did that instead, and I worked with them for a year. And this guy dislocated his shoulder during practice, and athletic trainers aren't legally allowed to relocate joints, but a lot of times they do because they're in situations where they're not going to get to a doctor for a while. So he was begging me to do it, and so I did it. But the way that you actually have to do it is you have to try to get something kind of underneath their arm like this, and then kind of pop it up. So a lot of times you stand up behind them and put your knee right there, and then put some pressure there. And you can see how that would kind of lift the humeral head out, and then it allows it to kind of suck back in. And after a few tries, we got it to go back in, but it wasn't on the first try. But he was my best friend after that. He was happy it went back in. That's always the thing with a joint dislocation, is it hurts like heck when it's out and when you're trying to get it back in. But then as soon as it gets back in, it's just this immediate relief. Because it feels so much better when it's in the right spot. But luckily he didn't get hurt worse because of me trying to put it back in. So yeah, so that was one there. So the shoulder, as I mentioned before, does have to rely a lot on muscles and tendons to support the joint. Okay, one of those is the biceps brachii muscle. Okay, and more specifically, the long head of the biceps brachii. Okay, biceps brachii has 2 heads. That's why it's called biceps, just like a bicycle, right? That means 2. Okay, it has the short head over here, which goes right up to the coracoid process. And then it has the long head on this side, which goes right through that intertubercular groove that you guys saw when you studied the humerus, right? Between the greater tubercle and the lesser tubercle, that little groove. And there's some ligaments that actually go over here and hold that thing down so it doesn't get out, okay? But that runs right up through there, and then it attaches right to the scapula there on the labrum, actually on the top of the labrum. And so that's an important stabilizer for the shoulder, because you can imagine that as that biceps contracts, it actually pulls the humeral head that direction into the socket. Okay, so that helps pull it and hold the joint together. Okay, so attaches the upper rim of the glenoid fossa, which is where the labrum is, glenoid labrum, and it pulls the humerus against that glenoid fossa. Okay, so that's an important musculotendinous stabilizer of the shoulder. And then, as I'm sure most of you know, we also have the rotator cuff in the shoulder, right? And there's 4 rotator cuff muscles, and they're shown here on the slide, okay? And I do want you to know the names of these 4. Even though they may not be written on that left side, they're written right over here, okay? And so the subscapularis is the only one that's anterior, okay? So we got this anterior rotator cuff muscle. It takes up the whole subscapular fossa, right? And then it attaches to the anterior side of the humerus. And then we've got 3 on the posterior side, right? You'll recognize this, that spine of the scapula, right? Just above it, supraspinatus, right? That means above the spine, right? So supraspinatus is the muscle that's above the spine. Just below it, right here, infraspinatus, right? So that's the one that's below the spine. And then below that, we have teres minor, okay? And those are the 4 rotator cuff muscles. There's only 4, okay? So subscapularis, supraspinatus, infraspinatus, and teres minor, okay? So their function is to pretty much wrap around the end of that humeral head, and when they all contract together, they all just pull the humeral head right into the glenoid fossa, right? Because you can see they all kind of attach around here. So when they contract, they just pull that head in, they cuff it right in, okay? And then they're also important decelerators of motion of the shoulder. And we'll talk more about what that deceleration looks like. But yeah, anytime we do an acceleration movement, like say we go to throw a ball, right? We throw this way, when we come forward, that's the acceleration. And then we let go of the ball and we need to stop our arm, right? So we throw it, we let go, and now we need to stop it. So we have muscles that contract and kind of pull our arm back to slow us down and help prevent injury, okay? And so those rotator cuff muscles are important decelerators of shoulder movement. All right, what questions do we have so far?
It was actually back on the bicep one.
Sure.
One's the long head. I didn't really
Oh
understand.
yeah, so the long head is this one here. And the short head's on that side. So long head is the one that goes up through through that intertubercular groove there. And then the short head is the one that goes right to the coracoid process. And the long head is the important stabilizer for the shoulder.
Thank you.
You bet. What else?
So for the bones, since we memorized all the structures, or not all of them, I'm sure, but a lot of them, is there any like keywords like fossa or cavity that we can expect? Like, oh, there's probably a muscle originating from here.
Yeah, good question. You know, mostly anything that sticks out in any way, whether that's a tubercle or a tuberosity or yeah, any of those different kind of points that are projections typically have a muscle coming off of them, okay? Unless they're inside of a joint, right? We have the condyles, which are a little bit different, but that's inside of a joint. But an epicondyle will typically have a muscle attached to it or a ligament. And so, yeah, anytime you see those, or even crests and lines, most of the time, if there's anything that kind of rises up off of the bone, then it's that way specifically because a muscle attaches to it.
Perfect. Thank you.
Yeah, it's a great question. All right, what else we got? Any other questions so far? Okay. All right, so let's go ahead and do this one. All right, give you about 10 more seconds. All right, that looks like about everybody. Okay, see what you said. Good, absolutely. So 94% of you are saying C, subscapularis. That is the one on the anterior side. The other 3 are on the posterior side. Perfect. Okay. All right. So a little bit more about the shoulder. The shoulder has a labrum. Okay. This is again, fibrocartilage. There's a lip of fibrocartilage surrounds the joint. We can see that clearly here. And this helps a lot. This increases the contact area of the two bones by 75%. So it almost doubles the contact that the humeral head has with the scapula. Okay. And so very important for shoulder stability. Okay. All right. Okay, let's do this one here as well. All right, give you about 5 more seconds. Take a guess if you're not sure. Okay, looks like we got everybody. Okay, so we're between D and B, it looks like. So let's take a look at that. So a shoulder dislocation is an injury to the blank. So we got D and B, both have glenohumeral there. Okay, so that's definitely true. So this is glenohumeral. Okay, and a shoulder separation is an injury to the blank joint, and that's going to be the AC joint, the acromioclavicular joint. So D is our correct answer there. All right, and we can damage our sternoclavicular joint. It's just not called a shoulder separation when we do. It doesn't have a cool name like that as far as I know. It's just a sprain. Okay. All right, so let's talk about the other upper extremity one that we'll talk about today, which is the elbow. The elbow is made up of 2 primary joints. Okay, so we have the big one that we think of when we think of the elbow, which is the hinge joint, the main part of it. It's where the humerus and the ulna articulate. And that's right here, right? So right between the trochlea of the humerus and the trochlear notch of the ulna. Okay, that's the hinge joint. And hinge joints allow for uniaxial movement, right? And typically those are always going to be sagittal plane movements. So flexion and extension is what it's called. So flexion is when you bring it up, right? And extension is when you go down with it. Okay, so that's the first joint. Second joint is the radius and ulna joint. Okay, and that's really this one right in here. Okay, that's known as a pivot joint. Okay, and the type of in the plant, well, I'll just write it in here, sagittal there, and this one, this pivot joint one, is more of a transverse plane movement, right? Because it's more of like a rotational movement. And so again, that's supination, pronation when we're doing that. So right here, I'm supinated, I go there into pronation, right? And literally my radius flips over to be on the other side of my ulna when I do that, right? And that's all about that spinning of the radial head in the radial notch of the ulna right there. Okay, there's definitely some involvement right there too, the radius and the capitulum of the humerus, but it's not the primary joint surface. They're not always really touching each other like they are the other side already is. Okay. All right, so that's the elbow joint complex, and let's look at some ligaments here, okay? So you need to know 2 primary ligaments here. It's the UCL and the RCL, okay? The UCL is the ulnar collateral ligament, and you can see that here, okay? That one protects against a movement that's called valgus, okay? And we'll see valgus in the knee as well. And so in the elbow, the way valgus looks, so if I've got my elbow here, if somebody were to kind of push on the outside of my elbow, and then it opened up this in the medial side of the joint because they're pushing on this side, that would be a valgus type movement, okay? So it's like when your elbow's like this and then they go like that, right? There's some pressure pushing from the outside and that opens up the inside, okay? So the most common way in sports that people damage their UCL is by throwing. right? Because they bring their arm back like this, and when they bring it back, it's opening up this joint surface, this joint structure right here, putting stress on that UCL ligament, okay? So that's on the medial side. The one on the lateral side is called the radiocollateral ligament, and that one protects against the opposite motion, which is called varus, okay? And so varus is the opposite. If we're holding our, put it down again, if we're holding our arms out like this, then varus occurs when somebody's pushing from the inside and it opens up this outside part, okay? So varus is that way, valgus is pushing from the outside in, varus is pushing from the inside out, okay? And this is showing the radial collateral ligament on that image there. Okay, so when we have a UCL injury, this is the kind of the famous injury that we hear of in professional baseball that a pitcher gets, and this is the one that requires Tommy John surgery. And Tommy John was just one of the first people to have this surgery, and I'll show you what it looks like here. So when the damage is here to the UCL, what happens is the surgeon goes in, opens up the forearm, and actually pulls out the tendon from this guy here. And this muscle is called the palmaris longus. And this is a muscle that we'll see in the cat and the human. So palmaris longus is this tiny little muscle, and you'll see it in the cadaver video. The muscle belly is literally like this big on the cadaver that we have in the lab, in the video that I show it. And then the rest of it's just this long tendon. And then that muscle's only job is really to tighten up the connective tissue inside your palm when you grip. And so you can see why when the surgeons got in there, they thought, well, this thing must not be doing much. We're going to use it for something else. So that's literally what they do. They cut the tendon here. They take that part of the tendon, and then they drill holes through the humerus, through the ulna right there, and then they weave this thing through in this kind of figure 8 pattern, and that recreates the ulnar collateral ligament, and that's Tommy John surgery. It's about a 13 to 14 month recovery with Tommy John surgery. If some of you are baseball fans, then you know, and when your favorite pitcher had that happen, they missed not only typically that season they're a part of, but then most of the next season usually too, because it's such a long recovery. But the thing is, some guys come back and they're throwing harder than they were before the surgery because they got it nice and tight in there for them. So that's the Tommy John surgery. Any questions on that?
So the UCL is medial?
The UCL is medial.
Okay.
And the RCL is lateral. Good. Absolutely. Yep. Okay. Anything else? Okay. So that's what we're going to talk about with the elbow. Now let's get into some of the lower extremity joints. We'll talk about the hip, the knee, and the ankle here. Okay. So the hip is also a ball and socket joint. Okay. Has a pretty large range of motion. Nothing like the shoulder, but still pretty large. Okay. It's way more stable than the shoulder, as we talked about last class. And there's multiple reasons for that. Number one is the socket's way deeper, so we have that structural stability, right? That was all about the structure. Very strong ligaments, okay? And then we also have this acetabular labrum, fibrocartilage rim around the acetabulum that helps deepen the socket even more. Okay, one ligament to know here is called the iliofemoral ligament, and it's kind of this V-shaped pattern here. And so this is kind of anterior, mostly anterior, a little bit superior of the hip joint. And it's the strongest ligament in the body. This was the one I was trying to remember the number of last time in class, but its tensile strength is about 772 pounds, right? And so it's really hard to sprain that guy. And when you're standing, when you're kind of standing and you kind of like rock your hips forward, and sometimes you can kind of like rest on your hips when you do that. That's really what you're doing, is you're putting pressure on that iliofemoral ligament, and it's pretty much just holding up your weight when you kind of like rock your hips forward with your hands on your hips there. So incredibly strong ligament there. Okay, let's talk a little bit about the knee. The knee, as it says there, is the largest and most complex joint complex in the body. Okay, it's kind of like a hinge joint, but it's a little bit different because it's not only that you can flex and extend your knee, but you can also rotate your knee a little bit too. Okay, so it's mostly flexion and extension. that sagittal plane movement, but there's a little bit of rotation. And the way you can do that is, see, most of you are sitting at a chair or on a couch or something. If you have your knee bent at a 90-degree angle, you can pretty much just take your foot and start turning it inwards as far as you can, and then take your foot and turn it outwards as far as you can, and put your hand right on your tibia, on the top of your tibia, like underneath your patella when you're doing that, and you'll feel your tibia kind of moving, rotating both ways. Try it while you're sitting there. Yeah. So you can kind of feel that tibia moving back and forth. That's the rotation of the knee, right? So it allows for a little bit of that to make it not a pure hinge joint. Okay. All right. So the knee has 4 bones in it as well. It has the tibia, the fibula, the patellar, and the femur. Patella, and the femur. So 4 bones. Okay. And then it's got 3 bony articulations. Okay, so the main one between the femur and the tibia, that's those big condyles from the femur hitting the tibial plateau. Okay, we also have the fibula and the tibia. So we have this little articulation right there. That one doesn't move much, but you can feel that one when you're doing that rotation of your knee. You can feel some slight movement in there. Okay, and then we have the patella sliding over the femur right here. Okay, that's kind of our last articulation there. That patella slides back and forth over the femur. Okay, and as we've already mentioned, the cartilage in the knee, we have the medial and lateral menisci. Okay, these are very helpful for deepening the articulation, shock absorption, and then really kind of giving us some more stability from any lateral or medial movements of the knee, as well as rotation. Okay. All right, so let's talk about the ligaments of the knee a little bit, and then I'm going to show you on a model I have here next to me, kind of what that would look like, and what the different how to stress those different ligaments. Okay, so the one that I'm trying to remember, who was that? Was that Maddie that said that you dislocated your patella multiple times?
Yeah.
Yeah. Okay. Yeah. Well, so we used to teach these ligaments here, these patellar ligaments, or the patellar retinacula, but we just don't anymore. But I just left them on there because they're on this image. You don't have to memorize those ligament names, but we see these ligaments that are actually connected to the patella on both sides, and they're holding it down to the tibia mostly, but also to the femur. And so those are the ones that are probably loose on you, Maddie. I don't know. Have they mostly been lateral dislocations? Do you remember which way it went?
Yeah, lateral. And then I had surgeries to get like them tightened up. So
Did that help?
I haven't done it since.
Oh, sweet. Okay, good. Yeah. Yeah. So it's lateral. Yeah. And that's definitely the more common way for them to go is laterally. So towards the fibula over here. And that would mean definitely that these medial ones were super loose. And those are the ones they probably tightened up for you. So yeah. Okay, well, why don't we do it this way? I'm going to just show you this image here, and or not this image, but this model. We'll see how this works. I might have to take my headphones out. But yeah, so we've got a big knee model here. Okay, so you can see the hip up there. So this is a right knee. Okay, and I'm going to get you in a little bit closer there so you can see. So we have some large ligaments right here on the side. So this is a medial side. This is a lateral side. Right, so medial, we've got our large medial collateral ligaments, all right, our MCL there, okay, and then on the other side we've got our LCL, okay, so you can see LCL attaches to the fibula right there, okay, and then on the medial side we've got our MCL, medial collateral ligament, okay, and then since I pulled the patella out of the way, we can get inside there and actually see those cruciate ligaments too, okay, so we can see those cruciate ligaments, we can see this one coming medially and going that way. So you can kind of see the one that's more anterior, that's the ACL. That's the anterior cruciate ligament. And then behind that, if I kind of move the ACL out of the way a little bit, you can kind of see the one behind it. It's much thicker. That's called the PCL, or the posterior cruciate ligament. Okay, so that's kind of that. The thing we'll talk about in a second is the forces that damage each of these ligaments. Okay, so when you think about valgus, that force we mentioned, or I mentioned in the elbow, again, that would be something pushing from the outside and opening up the medial side of the joint. So a valgus force would do this, right? So you hit it from the outside, opens up that medial side, and you can see how that would stretch the medial collateral ligament, right? It stretches that MCL, okay? If we go the other way, if we hit it from this side, and then it opens up that lateral side of the joint, that is the varus, or V-A-R-U-S, okay, motion, and that's going to open up the lateral side of the joint, okay? When you tear your ACL, it's typically something like this. You typically have some valgus, but then you also have some rotation too, like that, and the femur kind of doesn't just go straight into valgus, but it goes like this, and then it rotates as well, and that's usually how the ACL tears. It's usually a mix of valgus and rotation. Okay, any questions on that knee while I've got the model here for you that I could help, that I could point out anything? Okay, so why don't you guys on your clicker app there, why don't you guys send in the answer to that question there on the letters, which would just be which one of those is the MCL. All right, give you about 5 more seconds. Okay, anybody else? All right, see what you guys said. So MCL, about half of you are saying D, and then we have a few saying C and a few saying B, okay? So C and B are the ones that are those patellar retinacular ligaments, okay? So this one is there, C is there as well, okay? And then D is definitely the MCL there, okay? Now, by looking at that image, the only way that I can tell that I'm on the lateral side or medial side is the fibula, right? The fibula tells me that that's the lateral side, right? And so then I can tell, all right, well, if that's the lateral side, then this collateral ligament there must be the medial collateral ligament, okay? And so then A is the LCL, whereas D is the MCL. Okay. One thing that's kind of interesting about this, just kind of weird, is this thing called the patellar ligament, okay? This is E there, it's labeled as E. That one, I mean, it's not, it is a ligament because it connects bone to bone. It connects the patella to the tibia, but really it's part of the tendinous, musculotendinous structure, right? Because it's helping the quadriceps attach to the tibia, okay? So that's this whole thing right here. Patellar ligament, but most people just call it the patellar tendon because it's really a part of the muscular structure attaching to the bone. Okay, and then we have the medial and collateral ligaments. Like I just said, they prevent varus and valgus. Okay, so the one that prevents varus is our LCL. One that prevents valgus is the MCL. And we can't see the cruciate ligaments here, but we'll see them in a sec on the next slide. With the kneecap removed. Okay, any questions about these ligaments here before we keep going? All right. Okay, yeah, here's the LCL and the MCL function here. And this is kind of a nice image of looking at varus versus valgus. So take a look at this guy, that knee right there, and you give us a vote on which ligament that guy sprained. And first, just say to yourself, which motion is that? Is that valgus or is that varus? And then which ligament did he most likely sprain there? That's his left knee, right? So it's kind of hard to tell what's going on there. Whose leg is whose, but I see a lot of people doing that. Hopefully not bringing back too many traumatic memories for some of you. Brett doesn't want to look at it. You can just keep your eyes closed, Brett. I'll tell you when I change the slide. Okay. All right. Anybody else? Go ahead and vote. Just A or B there. Which one did he sprain? Okay. All right. So let's see what you guys said. So most people are saying B, the MCL for sure. So that's definitely a valgus motion that we see there. Okay. So if there was somebody hidden, it would be kind of coming from the outside and opening up the medial side and spraining his MCL for sure. Okay. Now, could he have torn something else? Most likely. He probably also tore his ACL and his meniscus doing that too, but for sure we see the valgus pretty clearly. But that's a pretty extreme valgus, so most likely got his ACL as well. Okay, so the function of the ACL and the PCL, and there's a little bit of a kind of relativity to this, okay? When we think about the femur on top moving on the tibia, if we think about the femur moving one way and the tibia being stable, it's going to be the opposite of the femur being stable and the tibia moving the other way, right? So think about it this way. So the ACL prevents the femur, so the femur from sliding posteriorly on the tibia. Okay, so in that case, we got our tibia here, our femur here. The ACL is going to make sure that the femur doesn't go backwards. Okay, but that's actually the same thing for as far as the ACL is concerned as the femur being stable and making sure that the tibia doesn't go forwards, right? Do you see the same thing? Because it's just doing this motion, right? And so we could say the ACL prevents the femur from sliding posteriorly on the tibia, or we could also say the ACL prevents the tibia from sliding anteriorly on the femur. Okay, the PCL is the opposite. PCL prevents the femur from sliding anteriorly, so prevents the femur from sliding anteriorly on the tibia. Or we could say the femur, or the PCL prevents the tibia from sliding posteriorly on the femur. And we can see them here. So here's the ACL, that one right there. And here's the PCL, it goes behind it that way. So ACL goes medial to lateral, PCL goes lateral to medial. And now cruciate means cross, right? So they cross in the center of the knee. Normally at this point in class, I would have you get up on the table, one of you, and work with your partner to do some little special tests on your leg to actually test out each other's ACL and PCL. But it's a little trickier. I see most of you are by yourselves for the most part. Got a couple partners there. I see a couple, but not too many. So yeah, next time. But yeah, so that's ACL and the PCL. So let's talk a little bit about injuries of those. So the ACL sprain, again, usually results from a combination of valgus and rotation. Okay, and the weird part about ACL sprains is they're typically non-contact. Okay, they're typically somebody's running and they plant their foot and then they cut and change directions and try to go the other way. And when they do that, their foot stays stuck in the turf or the ground, and then their body moves on top of that and rotates, and then their knee falls in that valgus motion along with rotation. Okay, so if you tear this ACL, there's some conflict on this, but for the most part, people think that there's really no such thing as like a minor ACL sprain. It's for the most part, you either tear it all the way or nothing. And so when you do sprain it, it's most of the time completely torn. And there's and it requires surgery for the most part. There's the most common one initially was this, what's called the bone patellar tendon graft. So the surgeon will cut out a chunk of bone from your patella, cut out a chunk of bone from your tibia, slice out the middle 1/3 of your tendon, and then that becomes your new ACL. And you can see they literally drill a hole in the tibia right there, drill another one in the femur right there. And so the bone part of each side stays in the bone. They put some screws in to hold these down. They get it to the exact right tension, just lock it in place. And that actually converts into a ligament instead of being a tendon. The tissue actually converts. So that's one. It's also very common to do a hamstring graft. So to take one of your hamstring tendons, your semitendinosus tendon part of it, and use that instead. And then that other hamstring, that can kind of use the hamstring that's next to it to connect to the tibia. Okay, so it's more common in females than it is in males. There's multiple reasons. One of them is just what's called the Q angle, which just has to do with the angle from the hips down to the knee. It's a little bit larger in women because of the because of the pelvic differences that we already talked about in class. And so that puts them in more likely of a position to go into that valgus motion. Okay, so that's one. There's multiple other things. There's some connections with estrogen, and estrogen actually weakening ligaments at certain time periods. There's also connections between the strength of the quadriceps versus the hamstrings, hip muscles, all kinds of things. But there's definitely a gender difference there, a sex difference there between males and females. So, yeah. Okay. Any questions on that?
I have a question.
Yeah, go ahead, Brett.
What is the cause for non-contact ACL tear if there's no real twisting involved, if it's just like deceleration? A lot of people just like plant and therefore gets caught in the turf or something, and all of a sudden they tear their ACL. Yeah,
you can do that. Sometimes the other thing could be hyperextension too, and you know that's somewhat of a common way to do it as well. Is hyperextending, and then that would be where that femur kind of slides backwards on the tibia, right? That foot's planted, you hit here, and then it slips backwards, and probably with a little bit of valgus too to put that stress on it. But pure hyperextension can cause it too.
Got it.
Yeah. So. Okay. So that's ACL. MCL sprains are very common. Usually comes from that straight valgus. They don't require surgery, most likely. Almost never do you have a MCL surgery. They heal on their own, but they are very painful and they cause a lot of instability. So you have to be off of it for quite a while. A lot of times the medial meniscus gets torn along with the MCL when you have an MCL sprain. Okay. All right, let's go ahead and do this one. So now I'm flipping the wording on you here, okay? Instead of the femur moving, I'm talking about the tibia moving now. All right, go ahead and send it in when you're ready. All right, gonna shut it off. See what you guys said. Okay, so about 70% of you are saying A. So the ACL prevents the tibia from sliding anteriorly on the femur, whereas the PCL prevents the tibia from sliding posteriorly. And that is correct. And that's the easiest way to remember it. I think of it that way, with the tibia moving instead of the femur, because then you got the same motion. Anterior goes along with anterior, posterior. Posterior goes along with posterior there. You just have to remember that if the question is worded the other way, then it's the reverse. The other way meaning the femur moving instead of the tibia. Okay, let's talk about the ankle here briefly. We've only got a few minutes left, but the ankle complex is also, there's a lot going on here as well. There's 4 bones involved: the tibia, fibula, talus, and calcaneus. Okay, there's 2 primary joints in the complex. The talocrural joint, remember we talked about in lab, that crus is what's caused or what's created by the fibula and the tibia coming down. This is the crus right here, right? Kind of creates this little cradle-like thing to receive the talus. Okay, that's what allows for what's called dorsiflexion and plantar flexion. So that's pushing down on the gas pedal. That's plantar flexion. Pulling your toes up towards your shin. That's dorsiflexion. That's a sagittal plane movement. Okay, but then we have what's called the subtalar joint. And this is really between the talus and the calcaneus. And this one allows for inversion this way and eversion that way. Okay, so inversion, think of what happens when you think of like rolling your ankle, right? You roll it to the outside, that's really inversion. When you go the other way, try to roll to the inside, but you can't move that very far that way, that one's eversion. We also have this joint up here, the syndesmosis joint, that's called a high ankle sprain. And you hear of those sometimes in football. And those are in the joint called the tibiofibular joint. And there's a ligament there, the anterior tibiofibular ligament. Okay. All right. Let me just show you this real quick. It's just a 1-minute video that kind of shows you those motions really well. It's hard to...
All right, so ready, everybody? So Pulling up this way is going to be dorsiflexion, pointing down, plantar flexion, going in towards the midline of the body, inversion, going away, eversion. So remember, if I'm doing it passively, that's me moving it, okay? Passively, if it's
Yeah, that's all you really needed to see was just, yeah, that what plantar flexion, dorsiflexion, inversion, eversion. Okay, and then let's just briefly look at the ligaments here. So the ligaments on the lateral side are the ones we most commonly sprain. Okay, the most commonly sprained ligament is right here. It's called the ATFL, or the anterior talofibular ligament. Okay, you need to know these three, the ones I have circled there. You need to know that one, as well as the deltoid ligament. So all the ones on the lateral side are ATFL, okay, anterior talofibular, CF ligament, the calcaneofibular, or the PTF ligament, the posterior talofibular ligament. Those are the ones that we most commonly sprain. 85% of ankle sprains occur on the lateral side, okay? And then on the medial side, we have we have the deltoid ligaments here. And so they're shaped kind of like a triangle, like a pyramid. And those are on the medial side, and they prevent eversion, whereas the lateral ones prevent inversion. Okay. All right, and that's pretty much what I've got here for you guys today. Yeah, if you guys have any questions, you're welcome to hang out a little bit here after class, and I'll field any questions you have. If not, I will post a video for Wednesday's class, and that'll be the gross muscle anatomy, kind of looking at the microstructures of muscle and kind of some other characteristics of muscle. And then we'll see you back on Thursday for your synchronous lab, or if I don't have you for lab, then I'll see you on Friday for the TBL day. All right, guys, good to see you all.